So basically today's topic is about oxygen therapy and hypoxia. So first of all, we need to know why there is a need to have oxygen or to give oxygen to the patients. Right. So for that we have certain indications. So hypoxia is one of that. ठीक है, and the treatment of type 1 respiratory failure is actually oxygen therapy, and you need to identify the cause, correct it in order to reduce the requirement and also to make the patient well before going home. So basically we have these 9 steps of oxygen transport pathway through which we'll be navigating through the different areas of involvement because of which hypoxia happens. Okay, so first step is when we are breathing the air, it's not that we only have oxygen in the air, right? We have seen that diagram or a pie chart when we were in middle school, like 8th standard or something, that we have 21% oxygen which is present in the air, and rest of that is nitrogen and other gases like carbon dioxide and carbon monoxide, etc. So basically when we are breathing right now in room air, the oxygen content is 21%. This is the basic thing that everybody must know. Now, if we are not able to maintain our oxygen saturation at this 21% of fraction of inspired oxygen, we need additional or supplemental oxygen therapy in order to maintain the vital functions of our body. In order to correct the hypoxia, we need the oxygen. So starting from step 1, first the air that we are breathing in needs to have appropriate content of oxygen. So step 1 is inspired oxygen and quality of ambient air. So you must have heard about this condition that when people go to Ladakh or any higher altitude like Mount Everest or anything like that, they suddenly fall sick and start struggling with breath, and they require oxygen. Why is that? That is because the partial pressure of the oxygen, it reduces when you go up the altitude, and because of that the atmospheric pressure changes and we are not able to breathe in the oxygen, and oxygen binding capacity reduces. So after acclimatization, that is certain adaptation of our body to that high altitude environment, the RBCs in the body increases so that they can bind to the oxygen and the oxygen can be supplied to the whole body. So basically we need to have appropriate content of oxygen in the environment that we are breathing in. You must have heard this condition also when you see that the people slept in the car throughout the night in winter, and in the morning they were all expired. They could not, they were dead bodies in the car because they were sleeping in the closed environment, and the heater from the car actually took away or burnt all the oxygen, and it was filled with carbon dioxide. All right. So because of that, they did not have appropriate oxygen in the environment through which they were breathing, and that led to hypoxia, brain death, and ultimately death of the patients. So that is why whenever you are in the environment, you need to see there is proper ventilation in the rooms, or you are going up the hill in the higher altitude, you have to give your body some time so that it can adapt to that altitude and oxygen saturation can be maintained. All right. Now coming to step 2 of oxygen transport pathway. Can you just yes, this step 2, next. Now coming to step 2. Now the environment that you and I are sitting is absolutely fine. Okay. But the airway through which the air goes in needs to have patency. That means that if there is any obstruction in the airway, like if it's a fixed obstruction, like there is a tumor or any calcification or any foreign object which is there, it will obstruct the airway. It won't allow the air to go inside the lung. So this will also cause hypoxia. All right, so you need to correct it. Now there are certain uh, like temporary obstructions, or there can be inflammation or secretions which are there inside the trachea that is obstructing the air to go inside. That's why patients struggle to breathe when they have conditions like asthma, COPD, or bronchiectasis, when there is excessive mucus production or narrowing of the airways. So as you can see here that the resistance of the this air, that the resistance is given to the air by the airway, it increases 4 folds when there is 1 mm reduction in the radius of the airway. So that's how it is important. The more resistance will increase, the more difficulty the patient will have in order to breathe. All right. So that is why in order to reduce the hypoxia or make the air available or to make it easy for the air to move towards the lung, you need to actually have patent airways. So you will nebulize the patient, you will do chest physiotherapy in order to clear the secretions. All right, or if there is foreign object or anything like that, then surgical options are opted in order to remove that obstruction so that the passage of the air can be made easy. Now, this type of hypoxia are known as hypoxemic hypoxia. ठीक है, because the air is not going inside the lungs only. Can we move to the next slide? Next. Yeah. Now coming to step 3 of oxygen transport pathway. Now the environment was absolutely fine. The airway was also absolutely fine. But your lungs and chest wall were not normal. Like there was pleural effusion. Okay. Or there was collapse of the lungs. So when the air will not go inside the lung only, when the lung in itself is collapsed, how will the oxygen reach the blood, and hence the patient will develop hypoxia and require additional supplemental oxygen because to maintain vital functions and to provide oxygen to the vital organs. So these are the conditions in which the oxygen is compromised or the hypoxia happens, and this includes like pleural effusion, collapsed lungs. All right, along with that there are certain chest wall deformities also, because the chest wall, that is the ribs, the vertebra and the sternum, they need to expand in order to make the lungs expand. But if they are not able to expand because of any deformity like ankylosing spondylitis, because of any scoliosis, kyphosis, poor posture, all these things, then the lungs won't be able to expand as well, leading to the restrictive lung diseases, because of which lesser amount of air will be going in, and hence development of hypoxia. So you need to correct these causes in order to correct the hypoxia. But along the course, the oxygen therapy will be required to maintain the saturation and the functions of vital organs. So now coming to next step, that is step 4 of the oxygen transport pathway. It comes to the diffusion. Now basically diffusion is when the oxygen gets transferred from the alveoli into the capillary. Okay, the alveoli, this is the tiniest unit of our airway, the alveoli. The oxygen from our environment, our airway, our lungs conducting system, it reaches to the alveoli. Now from alveoli to capillary, there needs to, the oxygen needs to go to the blood and bind to the hemoglobin. All right, but if there is any sort of what you call secretions here in the alveoli, or the alveoli are collapsed, or there is fibrosis which is there, because of which the oxygen cannot cross this what you call this unit. All right, so this leads to diffusion defect, and because of this the hypoxia develops. Okay, so in order to correct that defect you need to correct the cause. That can see the permanent causes like scarring or ILD, that is basically not permanently correctable, so you need to manage it. But the causes like secretions retention or collapse of the alveoli, they can be corrected well with the right physiotherapy and pulmonary rehabilitation. So you need to make the patient do all those exercises so that the alveoli can expand, the oxygen can transfer from the alveoli to the blood or the capillaries and bind to the hemoglobin in order to get transfer. This type of hypoxia is also called as hypoxemic hypoxia because the problem is actually in the oxygen reaching the blood. Till now, the oxygen has not reached the blood only. If there is defect in the environment, airway, lungs and chest wall, and diffusion, all these four steps of oxygen transport pathway lead to hypoxemic hypoxia, requiring supplemental oxygen in order to meet the need of the oxygen of the vital organs. Now coming to step 5 of oxygen transport pathway. In this only we saw that there needs to be oxygen also, hemoglobin also, because that is the unit which binds to the oxygen and transport it to the heart. Now coming to step 5, which is perfusion. Perfusion is basically availability of the blood to take up those oxygens in order to take it to the heart so that it can be supplied to the whole body. Now perfusion can be actually what you call uh, mismanaged or imbalanced because of certain conditions. So imagine if there is not enough hemoglobin in the blood, the patient is anemic. All right, or imagine if there is any sort of shock, cardiogenic shock, ठीक है, infective shock or septic shock, any sort of shock which has reduced the blood to reach the alveoli to get the oxygen. That way the patient will develop anemic hypoxia. Okay, so perfusion is not, the ventilation perfusion mismatch will happen in that condition. Okay, so basically in a normal lung, the bases are more perfused because the blood is a little, it's heavier. So gravity dependent hota hai the perfusion. Okay, so in standing position, bases will be more perfused. In lying down position, the dependent areas will be more perfused. If you're lying down on the right side, then the bases of the right side will be more perfused. If you're lying down on the left side, the left side will be more perfused. So we use this also in order to make the oxygen transport to happen. So if there is any pathology, consolidation, collapse in the left side of the lung, then you will make the patient lie down on the right side in order to make the blood available to the oxygen to the good lungs, so that more this diffusion can happen and oxygen can reach to the heart and that can be supplied to the whole body. All right, so ventilation perfusion mismatch also needs to be corrected in order to make the oxygen reach the heart and rest of the body. Now, this was the step 5. This will also lead to anemic hypoxia if hemoglobin is not there only in the blood to take up the oxygen. Imagine that you have a lot of oxygen in the lungs. The lungs are absolutely fine. The environment was fine, the airway was fine, the lungs and chest wall was absolutely fine. There was no diffusion defect. The alveoli were well open and the oxygen was there. But there was nobody to pick the oxygen. Like you had to deliver a subject or a parcel, but there was not delivery partner available to take that parcel to the person you need to send it to. So what will be the use of that parcel? It will be of waste, right? So the hemoglobin works as that delivery partner. It binds to the oxygen and takes it to the heart. Okay, so this can be corrected by giving the patient, like correcting the anemia. You need to give blood or transfuse the blood as indicated, or give the patient medication supplementation so that the hemoglobin can be increased. All right, now coming to the next step, which is the step 6 of oxygen transport pathway is next. Next. Yeah, myocardial function. Now imagine that the lungs were absolutely fine, the environment was fine, airway, chest wall, okay, alveoli diffusion, even the hemoglobin was absolutely fine in the blood. Okay, so till now we have read about two types of hypoxia, which is hypoxemic hypoxia, which happens when there is some problem in the transport of the oxygen in the airway, in the lungs, or in the alveoli, or because of the defect in the what you call diffusion. Okay, that is called hypoxemic hypoxia. Then second type we studied was the anemic hypoxia, which happens because there is no enough hemoglobin to take up the oxygen. Now coming to circulatory hypoxia, which happens because of the problem in the heart. Now imagine the diffusion happened, the hemoglobin bind to the oxygen, now it is getting transferred to the heart in order to pump it out to the whole body, but the heart was not effectively pumping. Okay, there was some problem in the heart. Imagine there was heart failure, the coronary artery disease, or cardiac arrest, or anything like that. So if that happens, then the blood, which is oxygen rich already, it cannot reach to the vital organs, leading to circulatory hypoxia. Okay, so for that you need, that is why in conditions where there is heart involvement or pathology of the heart, the oxygen will drop, the saturation will fall, and the patient will manifest symptoms like shortness of breath, fatigue, and cyanosis. Okay, so you need to check the lungs as well as the heart when the saturation is dropping and supplemental oxygen is required. Now next steps comes your peripheral circulation. Step 7 of oxygen transport pathway. Next please. Yes. Now, if there is like problem in the circulatory system, your arteries, your vein, they are not effectively circulating or letting the blood circulate. For example, there is some sort of thrombosis, thrombus is there, embolism is there, there are narrowed, or like there is peripheral artery diseases or something like that is there, or if there is a rupture of the blood vessels somehow and there is bleeding or anything like that happen, then also there will be disruption of the transport of the oxygen to the vital organs and then manifestation of symptoms of hypoxia and desaturation. All right, so for that you need to correct the primary cause of peripheral circulation, like if there is any thrombus or if there is any what you call stenosis of the peripheral veins or arteries, then you need to correct that in order to correct the hypoxia. Now next comes the step 8 of your oxygen transport pathway, is your taking up the next please. Yeah. So till now we have studied three types of hypoxia. There are total of four. So we talked about hypoxemic hypoxia, anemic hypoxia, circulatory hypoxia. Now coming to cytotoxic or histotoxic hypoxia. This happens when the other systems are working absolutely fine. You're sitting in a nice environment where the oxygen levels are quite good, the air is quite good, your airways are absolutely open, there is no problem in your lungs or your chest wall. Okay, your alveoli are absolutely fine. The diffusion also happened, there was enough hemoglobin to take the oxygen to the heart was functioning well, your arteries and veins were functioning well. But now when the oxygen rich blood reached the tissues did not take it up. Okay, so this happened in cyanide poisoning, and this is known as histotoxic hypoxia when there is, because of the poisoning, the enzyme which converts the ATP into energy that stops working, and then there is desaturation because definitely the oxygen is not being used by the tissues, and then the requirement of the such supplemental oxygen occurs. So this is step 8 and fourth type of hypoxia. Now coming to the step 9, which is return of the partially deoxygenated oxygen into the lungs again. Step 9 of the oxygen transport. Next please. Yeah, so after this whole passage of oxygen, anything, any problem in any step will lead to hypoxia, a different kind. It needs to be identified, corrected in order to correct the hypoxia. Meanwhile, when the patient presents with the symptoms of hypoxia and desaturation, then oxygen needs to be connected in order to provide the additional supplemental oxygen. Then the primary cause of the hypoxia is corrected in order to make the lungs function well, or any other cause that has caused the hypoxia correct. Now, after the whole path, the carbon dioxide goes to the lungs and it is exhaled by mouth via us. Now, can you please take it down to the oxygen therapy topic? Next. Yeah. Now, one step here. So now, since we talked about four types of hypoxia, that is the hypoxemic hypoxia, the circulatory, anemic, and the histotoxic hypoxia. Each needs each primary correction, but when the patient comes with the reduced oxygen and hypoxia and saturation is reduced, shortness of breath is there, cyanosis is there, the oxygen needs to be connected. So these are the basic symptoms of hypoxia that you can notice and identify early. Like there will be shortness of breath, there will be bluish tint to the skin, lips and nails. There will be extreme fatigue because the in order to function and work, the muscles need oxygen, and if the oxygen is not reaching the muscles, the patient will experience extreme fatigue. Okay, there will be headaches also, there will be coughing or wheezing. The patient's pulse rate will become fast because the heart will try to compensate for the reduction in the oxygen in the blood. Slowly there will be confusion, there can be syncope, and then the patient can land into, if for 5 minutes if the brain's cell does not receive oxygen, they will go into, they will matlab, they, it will be irreversible damage to the brain, hypoxic brain injury, and then ultimately death of the patient. So it is a vital thing, and that's why as soon as possible you see these symptoms, you need to connect the oxygen to the patient. Now next slide please. Yeah, so there are certain one back, how to measure the oxygen levels. So you must have seen this during the COVID time also. This is called as pulse oximeter. All right, so this pulse oximeter get connected to the nail beds and it measures the, because of the capillary perfusion, it picks up the saturation level and it needs to stay above 94. Okay, so to anything between 95 to 100 is considered as normal. But if it's going below 94, 93, 92, 80, 89, it is not normal. It needs to be rechecked, of course, but this is one of the method that non-invasively you can measure the oxygen level. And then the invasive method is arterial blood gas analysis, which is most accurate, through which you can measure the PO2, PCO2, pH, and even bicarbonate ions. Now next, please. This is how it reflects on the monitor if you are working in the ICU. This blue one is the saturation of the patient. This is showing 88, but since the graph forming here is not correct, we will not say that this is the correct reading. You need to recheck it and see the graph forming, which should be like in a proper wave-like manner. Next, please. So these are the normal values. You will see the PO2 that should be above, like anything which goes below 75 or 60, it needs supplemental oxygen. All right. So we have to, in order to see the hypoxia, you need to see the PO2 levels. All right. Next, please. Just a second. Yeah, treatment, as I said, the treatment falls under three main categories: the maintenance of the patent airways, increasing the oxygen content in the inspired air, that is through the supplemental oxygen, and improving the diffusion capacity with positive pressure ventilation. Now next. For the maintenance of the patent airway, you will require aggressive chest physiotherapy, airway clearance techniques, using of the PEP devices, okay, and to reverse atelectasis, use of spirometer, acapella, etc., in order to make the alveoli open so that more gaseous exchange can happen and more oxygen can be transferred from the lungs to the blood. And you can use, in order to reduce the inflammation and the airway narrowing, the prescribed nebulization by the pulmonologist should be used to maintain the patency as well. Next, please. Now the third thing is supplemental oxygen. So this is indicated for low PO2, which is, if PO2 is going below 60, then you need supplemental oxygen. Or if the saturation is going below 90, then also you will need the supplemental oxygen. So that's why you need to measure the pulse oximeter and the PO2 both. Next, and that too you need to give the oxygen in a controlled manner, because too much oxygen can lead to CO2 narcosis, that is increase in the CO2 content, which will ultimately lead to development of the type 2 respiratory failure. So you don't want that. So you need to give the oxygen in a manner that it should be maintaining the saturation in the what you call given range, and the PO2 should be monitored throughout so that not too much oxygen is going on. Next, please. Next. Yeah, so coming to now how the oxygen is given. So basically, in order to give the oxygen, you need the oxygen source. That should be a cylinder, a concentrator, or if you are in a hospital, then there are oxygen supply throughout the hospital which are there. A flow meter is connected to the patient's this cylinder, and the flow meter basically measures the flow of the oxygen which is going per minute. All right, and the FiO2 is also monitored if a ventilator is connected or if the patient is using the different sort of what you call oxygen delivery devices. Okay, so we'll talk about the low flow oxygen delivery devices and the high flow oxygen delivery devices. So on the basis of the flow of the oxygen, the devices are divided. So the conventional prediction model states that for every liter of, now how you will start, how much you will start. So there is this conventional predictive model which says that for every 1 liter of oxygen, there is an 4% increase in the FiO2. Okay, so the nasal cannula gives 1 liter, if set at 1 liter per minute flow rate, can increase FiO2 to 24. 21 is the normal base FiO2 that me and you are breathing right now without any additional oxygen. But when you connect the oxygen at 1 liter, that 21 becomes 24. If you connect it to 2 liter, it will become 28%. So you are increasing the amount of oxygen in the inspired air. Okay, the percentage of the oxygen is getting increased by you are increasing the flow of the oxygen. All right, next please. So this is a typical example. If you are giving 1 liter per minute, it will make the FiO2 24. If you're giving 5 liters per minute, it's making the FiO2 roughly. This is an approximate idea. 40%. These are theoretical ideas. The practical values are always different, and also the different devices have different values. 10 liters will give you roughly 60% of FiO2. Next. Next. Yeah. So there's a wide range of oxygen delivery devices which are broadly divided into low flow and high flow. The low flow consists of nasal cannula, simple face mask, partial rebreathing mask, and non-rebreathing mask. So there are total four we'll talk about. Then we have high flow oxygen delivery devices which consist of venturi mask, high flow nasal cannula, and oxygen hood. Next. Next. Yeah, सबसे पहले the first one is the nasal cannula. Next please, we'll show the images first. Yeah, this is how the nasal cannula looks like. This is the most commonly used device, because delivery device, because at home also you will, the patient will get the oxygen through the nasal cannula. In movies also you must have seen the patients or the actors wearing it and connected to the bag or something, which is basically the concentrator bag. So we'll talk about nasal cannula. Can we move back to the yes. Yes. So the nasal cannula most commonly used. The maximum FiO2 that you can give to the nasal cannula is 44% with maximum 5 liters per minute. It will not increase the FiO2 beyond 6 liter. So it does not matter if you're giving 10 liters with the nasal cannula, the FiO2 will not increase. It will cause harm to the patient because the pressure will increase. It can dry out the mucosa, can cause epistaxis, and it will actually not work. So in order to move the flow more than 5 liter or 6 liter, you need to shift to the next delivery device. Now, prolonged use of nasal cannula may lead to drying of mucosa and crusting of secretions and may lead to epistaxis, like I told you. Now, coming to the second low flow delivery device, which is the simple face mask. Next, please. Yes, so the simple face mask is basically it starts working from 6 liter, 5 or 6 liter till 10 liters. So if the nasal cannula, like for example, let's take an example of a patient. The patient came in. Okay, the patient saturation was 60 saturation. Okay, 60%, and then you connected the patient to nasal cannula and started the oxygen at 4 liters. Okay, even on that 4 liter of oxygen with the nasal cannula, the patient saturation only reached till, for example, 75. Okay, you reached increases to 5 liter, 6 liter, but still it did not increase beyond 80% of saturation. So now when you are seeing that the saturation at 6 liter of oxygen with nasal cannula is 80%, then you have to increase more, you have to give more oxygen to the patient. But with that same delivery device, you cannot give beyond 6 liters. So you will shift to the next, which starts from 6 liters, that is a simple face mask. So then you will shift the patient to face mask. You will increase the flow to 7 liters per minute, and you will see the saturation is moving to 85. You will increase it to 8 liters, 9 liters maybe, and you will see that the saturation is moving to 92, 93. This is a hypothetical situation I'm telling you. It is not the actual case. The oxygen requirement depends on the patient and patient's condition. Okay, so it increased to the 90%, 95% with 10 liters on the simple face mask. So the simple face mask can be give maximum to 10 liter, and the fraction of inspired oxygen it will provide with that 10 liter is 60% only. So it is difficult. There are certain disadvantages also, that it is difficult to get a seal with the rice tube. The patients does not properly eat, or they have difficulty drinking water and everything. So there are certain disadvantages also. And if it is given below the given range of 6 liters to 10 liters, it may cause rebreathing of the carbon dioxide to the patient. That is why it needs to be maintained between the given value of 5 to 10 liters per minute of flow. Face mask ka picture is on the next slide. So this is how a typical simple face mask look like. So there's a clip, there's this strap which maintains the seal, this is the oxygen source, and these are the exhalation ports, so that the exhaled air can move out and fresh oxygen can come in with each breath. Now coming to the next low flow delivery device, which is the partial and the non-rebreathing mask. Okay, so this is how the partial rebreathing mask looks like, and this is the how the non-rebreathing mask looks like. The only difference between the two is that it does not allow the non-rebreathing mask. It has only one direction. Okay, so it moves towards one direction and it does not come back and mix. So the bag will be filled with complete oxygen. The flow will be unidirectional, and the fraction of inspired oxygen maximum theoretically can be given to 100%, which means all will be oxygen which is going inside the patient's lungs. So there will be 100% oxygen which will be given to the patient with this NRBM. Okay? Usually, typically in the ICU setups or in the clinical setups, you will use this. You will see this one. Rarely you will see this one. This does not have the valve, so the expired oxygen and inspired oxygen they gets mixed here. This is the only difference between partial rebreathing and non-rebreathing, as the name indicates. Now we can go to the back slide and see the difference between the two. Back, back. Yeah, so the maximum FiO2 is 60 to 80%, and in this one The maximum FiO2 is 80 to 100%. Okay, so basically this is exhaled oxygen. So I have told you about the both the differences, that there is one way valve in this one, so it does not allow any mixing of the oxygen and the carbon dioxide, and they both have a reservoir bag which allows the air to store, and a constant flow of oxygen is there. So this was about the 4 low flow oxygen delivery devices. Now coming to the high flow oxygen delivery devices. Next slide please. All right, next. Number one is the Venturi mask. Now, when we're talking about high flow, first thing is Venturi mask, because it will give you a very high flow, and the flow can be well documented, and it is absolute. Like in the previous devices, it was a range, okay, from 60 to 80, 100, or 44, or things like that. You cannot really tell how much of it is going in, and exact values, but with the Venturi mask you can actually tell the exact value of FiO2, because next please, on each Venturi mask there will be this, they are color coded Venturi mask. Okay, there's a hose with different, what you call, radius, so that the flow and FiO2 can be maintained with that. The lowest FiO2 is given by the blue one, which is 24%, and there is also written over these the amount of oxygen that needs to be given with the flow meter. So you, in order to achieve 24% of the oxygen FiO2, you have to keep the flow meter to 2 to 4 liters per minute. With the white one, you can give 28% with 4 to 6 liters. Orange one, 31%, and the maximum FiO2 can be given to 60% with 12 to 15 liters per minute of oxygen flow. They are color coded. It is written over them how much of FiO2 is there and how much of the oxygen you need to keep it on. Okay, so you will keep it on the exact given values. All right, and it will be connected. Next please. It will be connected like this is the mask. It looks like a simple face mask, but with the Venturi attached. So in order, and this is also a very good device when you are titrating the oxygen, or when you are increasing or decreasing the oxygen requirement of the patient. Okay, so for example, you started with the oxygen on 15 liters, and now the patient saturation and PO2 has improved, and you want to reduce the oxygen content. So by changing the device, you're just simply changing the venturies. So earlier the patient's FiO2 requirement was 60% on 15 liters. Now it is coming down to 40%, 8 liters. Okay, so you will change the venturi. Then further down, and you can take it up to 24% in 2 liters. Okay, and after that you can get the ABG done on the room air and see if the patient even requires further oxygen or not. Okay, next please. The next one is oxygen hood. We'll show the picture first in the next slide. This is how the oxygen hood looks like. Next please. Yeah. So basically, it's mostly used in the pediatric or infant population, not in the adult one so commonly. Okay, this is the hood, and the oxygen source is connected here. The air which is coming is already humidified. Okay, and the hood is filled with the oxygen. Constant flow is coming. Can we move back to the previous slide? Now, when you see previous slide, yeah. So this device is useful in infants requiring more than 40% oxygen. Okay, only then you will be given, and the flow must be more than 10 liters per minute to prevent CO2 accumulation. Since it's a hood, if the flow will be lesser, the oxygen will not be able to push the carbon dioxide out, and then there will be CO2 retention in the hood, and rebreathing will happen. So we do not want that. So only if the requirement is more than 10 liters, then only you will use this device for the infant population. ठीक है, probable complication of oxygen would include hypoxemia can be there, hyperthermia can be there, irritation to the neck, or pain in the neck that can happen. Now coming to the next high flow oxygen delivery device, which is the high flow nasal cannula. Next please. Yeah, so high flow nasal cannula basically is the same as the nasal cannula that we read in the low flow oxygen delivery devices. Okay, but here the nasal cannula is actually providing higher flow. It can give up to 100% of the oxygen, and the flow is maximum till 60 liters per minute. Can you imagine? Till now we were only talking about maximum 15 liters with all those devices that we read now. Even with the Venturi, even with the non-rebreathing mask, it was maximum 15 liters. But with the high flow nasal cannula, you are giving 60 liters per minute, which means if the patient's oxygen requirement is too much, that it is not being met by other delivery devices, then you can use the high flow nasal cannula. Since the flow is so much, the air which is coming through the nasal cannula, can we just see the picture first? This is how it looks like. So it goes in the nose only, like the nasal cannula, but see, you can, this is something different. Why? Because it actually provides pre-humidified and pre-warmed air, so that with that high flow there is no irritation to the mucosa, there is no epistaxis or anything like that. Now previous ones we can go to. One more. Yeah. So at the air oxygen blender, the inspiratory fraction of oxygen is set at 21 to 100%. We can change the FiO2, we can change the flow and slowly decrease or increase. Alright, it is pre-humidified, heated, so that it does not harm or irritate the mucosa. Next one, along with just the normal oxygen delivery devices, the HFNC actually have additional benefits, because the flow is coming out with such a high pressure and high flow, like 60 liters per minute you are giving. This also reduces the anatomical dead spaces. It will give additional PEEP effect. Like it is said, according to the researchers, it gives the PEEP value of around 3 to 4 centimeter of water. Okay, so that way it will keep the alveoli a little bit open also. So preventing of atelectasis is also happening. Recruitment of the airway is happening. So it is constant and with the good humidification. So you can say it is sort of a bridge between oxygen therapy, oxygen delivery devices, and the positive pressure ventilation with the NIV or ventilator. Because this is also giving some PEEP, this is reducing the anatomical dead space, and definitely it is providing such high flow of oxygen. So the topic for today, like we'll just quickly revise it. Yeah, so we'll quickly revise. We talked about hypoxia. In hypoxia, we have four main types of hypoxia. That is hypoxemic hypoxia, which happens when there is some problem in the airway, including the outside environment, airway, that is trachea, lungs, chest wall, alveoli, diffusion or gaseous exchange, which is being impaired because of problem in the alveoli. So all these step 4 of oxygen transport pathway, if they are involved, they are the cause of hypoxia. They are called as hypoxemic hypoxia. Correction of the particular step will lead to correction of the hypoxia and hence reduction in the oxygen requirement of the patient. Now, second comes the anemic hypoxia, which happens because of reduction in the hemoglobin, or there is, red blood cell which are reduced. Because of that, the oxygen which is available in the lungs is not able to bind to the blood cells and hence not be able to reach to the rest of the body. So the correction of that will be required to increase the oxygen content or to reduce the oxygen requirement of the patient. Third type was circulatory hypoxia, which means that the problem is in the circulatory system, including the heart and the blood vessels. If that is the problem, that needs to be corrected in order to correct the cause of the hypoxia and reduction of the oxygen requirement of the patient. The fourth type of hypoxia was the histotoxic hypoxia, which happens because of poisoning, cyanide poisoning, because of which the tissues are not able to take up the oxygen which is being transported to them. And hence, correction of that will be required to reverse the hypoxia. Meanwhile, when the patient comes with reduction in the oxygen, reduction in the saturation, additional supplemental oxygen is always started first as the first thing. PO2 is measured, cause is identified, corrected, and then the patient becomes better and oxygen requirement is reduced in the patient. So in order to give the oxygen, there are certain devices which are low flow oxygen delivery devices and high flow delivery devices depending upon the patient's requirement of the oxygen. So in low flow, we have nasal cannula, simple face mask, we have non-rebreathing mask and partial rebreathing masks. Then in high flow, we have oxygen hood, venturi mask and the high flow nasal cannula. These are the main devices that we use to deliver the oxygen to the patient, through which we also measure the flow and the fraction of inspired oxygen, titrate the oxygen, reduce and increase as per the patient's requirement, But even if with the HFNC the patient's oxygen requirement is not met, then the next best step is always mechanical ventilation of the patient.
For the full case discussion, visit www.assimilate.one. Watch for free.